sacral plexus is formed by the anterior primary ramus from L4, 5, S1, S2, S3, and 4. And as we can see, the major branches of the sacral plexus, yellow ones are from the dorsal division and the green ones from the ventral division. So these are the superior gluteal nerve, inferior gluteal nerve, the sciatic nerve, which is the biggest nerve in the body. Again, there is a common peroneal component and the tibial component. And the ventral division, it again gives branch to the nerve to quadratus femoris, posterior femoral cutaneous nerve, and the pudendal nerve. So as we can see in this image, the sacral plexus, after coming out from the vertebral foramen, it runs anterior to the piriformis muscle. So this relation is of much importance while we go to the multiple approaches to the sacral plexus block. And this is another image which is showing the different nerves. And in this image, as we can see, the sciatic nerve, sometimes all of us know that usually it tends to divide at the level of popliteal fossa, but in certain cases, it can divide as high as possible. And this is the cut section of the posterior thigh, showing the relationship of the sacral plexus. So this is the gluteus maximus, which is posterior, which has been dissected and cut. This is the piriformis, and anterior to the piriformis, the sacral plexus lies on the bed of these four muscles: the superior gemellus, the tendon of obturator internus, inferior gemellus, and the quadratus femoris. We can remember this by the acronym STIF. So now there are different approaches to sacral plexus which has been described, like the Tahaz approach, the Bentsen approach, Kazal approach, and the PIP approach. And you definitely need to know all of them, but you need to try doing one approach which you can develop your skill and you can do it more effectively. So again, the requirements remain the same as I mentioned about the lumbar plexus block. So this is the anatomy, or the patient is again in the left lateral position. I have marked it on the patient's body. This is the posterior superior iliac spine. This is the greater trochanter. This is the ischial tuberosity, and this is the medial cliff. So going to the first approach, this is the Tahaz approach, which was described by Ahmed Taha. And they mentioned that from the uppermost point of the gluteal cleft, if we keep our probe, ultrasound transducer, at the 8 centimeters lateral, then the ultrasound probe tends to lie on the ala of the ilium, which is a bony structure, and on ultrasound image, it will be appearing as a continuous hyperechoic line casting a black shadow. And the muscles above will be the gluteus maximus and the gluteus medius. And as you tend to move the probe caudally, you will be first reaching at the greater sciatic foramen. And as we move more caudally, we'll be seeing the sacral plexus coming out of the greater sciatic foramen. So as we can see, the medial border is formed by the sacrum, and laterally is the iliopubic eminence, again, this is a similar picture which is showing with the color Doppler along with the sacral plexus. Again, there are chances of vascular injury, and there are the inferior gluteal vessels and the internal pudendal vessels, which you could see in this image. So now coming to the scanning, as I mentioned, we need to go 10 centimeter lateral to the upper gluteal cleft. As I'm keeping my ultrasound probe at that level, I can see in the corresponding image here, and I'm trying to move my probe cranial and caudally. So as we saw here, this is the hyperechoic ala of the ilium, and as I moved more caudally, we can see on the medial side it is the sacrum, and on the lateral side it is the posterior border of the ischium. So the muscle above is the gluteus maximus. This is the piriformis, which has a hyperechoic shadow, and this is the sacral plexus coming out of it. As I wanted to show that, as we can see, as I move my transducer more cranial and caudal, this is the posterior border of the ischium, and medially is the sacrum, and this is the sacral plexus, which is coming out of the greater sciatic foramen. And this is how the medial will come from lateral to medial. Coming to another approach, the Bentsen approach, which says that you first mark the posterior superior iliac spine and the greater trochanter, and then mark the midpoint of that line. Next point is you keep the ultrasound probe at that level, and then you need to do the parasacral parallel shift, which has been described. So you move the transducer more in caudally, so inferomedially. So as we can see in this image, again, I have kept my probe and I'm moving more caudally. So what I'll see on the ultrasound, again, this is the ala of the ilium, and as I move caudally, This is the medial aspect, this is the lateral aspect, and again I'll be seeing the sacral plexus coming out of the greater sciatic foramen. Another thing about the Benston approach is that, as you can see, I am moving my transducer little bit caudally, and here on the right side of the image, you can see the sacral plexus or the coming out in the longitudinal section. So in Benston approach, we can see the sacral plexus coming out in the longitudinal view, whereas in Khar's approach, it is the transverse view. So along with the PNS, we need to deposit 20 to 25 ml of local anesthetic. This is the picture showing the Doppler. As we can see, the gluteal vessels, inferior gluteal artery pulsations in this image. Now coming to the third approach is the parasacral ischial plane block, which has been described recently by Dr. Madan Narayan and colleague. So what they say, it is similar to the Bernstein approach, and they mention that the sacral plexus lies in the fascial plane, which is formed anteriorly by the pelvic fascia and medially by the sacrum, laterally by the ischium and posteriorly by the piriformis and the gluteus maximus muscles. So as we keep our probe similar to that I showed in the Bernstein approach at this level, and we tend to move the transducer more caudally, we will get this image. This is the posterior border of the ischium and this is the sacrum. They mentioned that in this plane, after hitting the bone, if we deposit the local anesthetic, it will tend to move more medially and block the sacral plexus, as we can see from this image. So advantage of the PIP approach is that we are not targeting the sacral plexus directly. Our target is the bony landmark, which is the ischium, and thereby the chances of the nerve injury and trauma are less. So this is the scanning for the PIP approach. As we can see, again, this is the medial and the lateral. So this is the sacrum, this is the posterior border of the ischium, and this is the sacral plexus coming out. So if we insert our needle from the lateral aspect and target the posterior border of the ischium, we need to deposit around 20 to 25 ml of local anesthetic. Since we are not targeting the nerve, we can do this block without using the peripheral nerve stimulus. In the complications, again, similar to the lumbar plexus, sacral plexus remains the same. So we need to be aware of it. Now coming to the sciatic nerve, I'll just go in the continuation because we have discussed the sacral plexus. So as is the largest nerve of the body, which comes out of the greater sciatic foramen, and we can block it at the parasacral level, which I mentioned, at the subgluteal level, at the anterior level, and the popliteal level. So now coming to the more distal approach, the subgluteal sciatic. So at this level, the sciatic nerve lies between the greater trochanter, which is lateral border, and the ischial tuberosity at the medial end. The nerve lies between the gluteus maximus above and the quadratus femoris below. And quadratus femoris, it acts as a hammock between the GT and the IT, the greater trochanter at the ischial tuberosity. The requirements again remain the same like lumbar and sacral plexus, since it's a deeper block. This is a cut section of the thigh at the level of the greater trochanter and the ischial tuberosity. And as I mentioned, the sciatic nerve lies between the gluteus maximus and the quadratus femoris, and it acts as a hammock or a sling between the greater trochanter and the ischial tuberosity. Again, the sensory motor distribution, we need to know the dermatomal and the myotomal coverage. So with the sacral plexus block, it will cover most of the posterior thigh and the whole of the distal lower limb. Coming to the ergonomics for the GTIT approach or the subgluteal sciatic approach, in the left side of the screen, as you can see, I'm keeping my probe between the greater trochanter and the ischial tuberosity. And as we can see here, so this is the greater trochanter, this is the ischial tuberosity. The muscle above is the gluteus maximus. And as I move, we'll see a hyperechoic. This is the sciatic nerve, which is above the quadratus femoris. So as I mentioned, we need to use the PNS. So at this level, if we are looking for the evoke motor response, the inversion response is the most desirable response, because all of us know the medial, the inversion response is mainly because of the tibialis anterior and the tibialis posterior. The tibialis posterior is supplied by the tibial nerve and the tibialis anterior is supplied by the common peroneal nerve. So by getting an inversion response will be definitely, there are higher chances of blocking both the components as compared to the eversion and the dorsiflexion, because the eversion is mainly because of the peroneus longus and the peroneus brevis, both of which are supplied by the common peroneal nerve. And the needle will come from the lateral edge. So this is an image which is showing the sciatic nerve at the subgluteal level. So as we can see here, the gluteus maximus tends to thin out. The biceps femoris is the muscle which the comes at this level, and more anteriorly is the adductor magnus muscle. So after discussing the lumbar plexus, sciatic block, and the sacral plexus, now we'll discuss about the sensory innervation to the hip and blocks for the hip analgesia. So all of us know the anterior capsule of the hip is more painful because they have more of the nociceptive fibers, and they receive innervation from the femoral nerve, obturator, and the accessory obturator nerve. And this is the posterior image which is showing innervation of the posterior capsule from the superior gluteal nerve, inferior gluteal nerve, sciatic nerve, and now to quadratus femoris. And this is similar image which shows the dermatomal and the capsular innervation from the femoral nerve, obturator, and the accessory obturator nerve. So the block which I'm talking about is the PENG block. So this is the anatomical study, and it mentions that the anterior hip capsule is further divided into the four zones, and femoral nerve is the component of all the four zones. The medially we have the accessory obturator nerve in the superomedial compartment, and lower we have both the accessory obturator nerve and the obturator nerve, and the inferolateral we have femoral along with the obturator nerve. So now this is the image at the level of pelvic brim, and as I mentioned, the three nerves run towards the anterior capsule through the pelvic brim, and the target is to deposit the drug at this level in the PENG block. So it is also called as a pericapsular nerve group of block, and it is mainly for the hip analgesia, and we can give it for patient positioning before a neuraction. So how to go scan about it? We can keep our ultrasound probe at the anterior superior iliac spine, and then we can move it more inferomedially. So as we go more inferomedially, we will be at the iliopubic eminence. And the another approach is we can keep it at the level of the femoral or the inguinal level, and we tend to move our probe cranially. So as we can see here, we can use a linear or a curvilinear probe. 20 gauge 8 to 10 centimeter echogenic needle is required, and the local anesthetic is deposited in a plane between the tendon of the psoas major and the bone. So in this ultrasound image, this is head of the femur. I am going from at the level of the inguinal crease to above. And as I move cranially, we can see this classical image like the psoas tendon and the iliopubic eminence. So the needle will come from the lateral aspect, and we can deposit around 10 to 15 ml of the local anesthetic.